Hello, my name is Jeffrey Frank. I'm a clinical professor of emergency medicine at the University of Alberta and a visiting professor in disaster medicine at UPO in Novara, Italy. It is my pleasure to present a short abstract on work that I did with my co-author, Francesca Virginella from Bolzano, on the assessment of the validity and reliability of a new triage tool for avalanche mass casualty incidents, the cardiac arrest avalanche triage tool. Declare that we have no conflicts of interest. Just as a background, there are approximately 150 deaths per year related to avalanche, and those are for various sources, including asphyxia and trauma, and that the current treatment guidelines date from 2010, which were written by Bogle. Francesca Virginella, who's the content expert on this topic, was concerned with other providers about two major limitations of the current tool, which was a lack of adequate definition for the role of ECMO and a lack of guidance when the number of cases overwhelmed the number of providers, or what we might call disaster avalanche triage. The objective of this study was to create a reliable, valid, and accurate triage tool for use in mass casualty avalanche scenarios. Our hypothesis was that we could create a triage tool with an overall accuracy of greater than or equal to 80%. This level of 80% was chosen. It's somewhat arbitrary, but it is approximately on level with the accuracy of other types of disaster triage. If you compare it to things like START and SORT and SALT, generally an overall accuracy of approximately 80% is considered quite reasonable. Once again, quite arbitrary. How did our methods work? First of all, there was ethics approval from the ethical committee in Bolzano to proceed with this study. And the study proceeded basically in three phases. The first was development of the new tool through the focus group. The second was assessment of reliability and validity of the tool among experts. And then thirdly was the assessment of the accuracy of the tool among non-expert providers. One of the major issues with this study was, of course, that we needed a number of simulation cases to test the accuracy of this new tool. The cases were extracted from the file archive of the Alpine Rescue System of the South Tyrol, which were cases that had covered the last 10 years of avalanche rescue. The initial idea in this study was to obtain adequate detail from the database to reconstruct completely the avalanche cases and correlate that with their final outcome. Unfortunately, what we found in this database search was there was insufficient detail available to actually construct these cases. So in order to proceed further, what we did was basically interpolation of clinical data into these true cases. So we started all of the cases, the simulation cases are based on true cases brought from the file archive, but they required some interpolation of clinical data, and we call these sort of hybrid cases. In the final survey, we basically had 3 cases, each containing 15 patients. So there was a total of 15 patients divided into basically 3 scenarios. And again, this was to replicate the scenario of a mass casualty incident where basically the resources would be overwhelmed by the number of cases. And then the third part of this, our methodology involved a survey. And the survey was basically distributed through the Italian Helicopter Emergency Medical Systems Association and was really open to all providers who self-identified themselves as likely to be involved in field avalanche rescue. Overall, 270 people were invited, and those people who were invited were asked to basically run through these 3 scenarios, each with the number of patients in it, and there was one of 8 possible outcomes as per the tool, and I'll show you exactly what that means when we come up. So to talk a little bit about the results. Following the focus group was developed with 4 experts in triage rescue. All of these are people who are 2 were anesthetists, 2 were emergency physicians, and all were very, very familiar with triage and with avalanche rescue. And these people went through an iterative process in the focus group to try to develop the tool. And this is basically the tool that they came up with, which we are calling the cardiac arrest avalanche triage tool. What you will see, if you look to the right of the tool, when you come in, you see avalanche with buried people, and it divides right away multiple victims, yes or no. So if you go to the right of the tool where it says no, this follows pretty standard avalanche triage. Where we were really making our contribution is when there was multiple victims, and here we had to look at basically another way, which involved not just treatment of an individual patient, but how do you treat the most victims, do the most good for the most people. And here you can see the treatment is basically based on vital signs, because generally patients who are in avalanches, if they have adequate vital signs, basically then we can just triage them using START criteria, using any other type of MCI criteria. In this case, we chose START. And then if they do not have vital signs, then we start looking at burial time, providing them with CPR. And then you can see that there are a number of possible ways this can go. So it can go in that you end by doing START triage, post-resuscitation care, stopping, ongoing CPR. And these are the possible outcomes. So the tool's a little bit complicated. Again, our contribution to this was the creation of that part on the left, which has to do with multiple victims. So after development of the tool, 4 experts who were uninvolved with the tool development, who had not been involved in the focus group, were asked to assess these 45 simulated patients. What did we find? We found an inter-rater reliability when using the tool of 0.86. And interestingly, when we asked them, don't use the tool, just use your expert opinion, their inter-rater reliability was 0.85. So you see quite similar inter-rater reliability of expert opinion versus the tool. To assess the validity of the tool, we looked at, of these experts, how often did what the tool asked them to do agree with their own expert opinion. And we found that in 97% of cases, so the 95% confidence interval is 93 to 99%, that the tool agreed with expert opinion. So we consider this to be adequate validity and adequate reliability to continue on with the study. Now, the question of which cases to include in the third part. So in the third part, we're assessing the accuracy, or how often did the providers actually guess the right, or get the right triage decision using the tool. So what we did to make the survey for the third part is we only included those 39 cases where the experts were in 100% agreement with each other and with their own clinical judgment. Okay, so those cases form the test instrument for the online survey. The reason being, of course, it's very hard to mark someone correct or incorrect when we don't have an expert opinion that supports what correct is. So that's why we moved to those 39 cases. So, and then in the part 3, this was the survey of the non-expert providers. They contained those 39 cases. We found 115 of the 270 providers invited completed the survey. Now, the accuracy using the tool among the non-expert providers was 63%, with a confidence interval of 57 to 68%, which, as you see, is well below our desired 80%. And we found that only 43% of the providers had a greater than 80% accuracy. And, one of the interesting things I was told in my quality assurance courses during my statistics master's degree was always plot the data. And we actually plot in a histogram. You can see here on the y-axis is the number of survey participants who reached that level of accuracy. And then on the x-axis is the accuracy between 0 and 100%. And you see there's a big chunk who got between 90 and 100% accuracy. Okay, so we had 35 people who, using the tool, had that accuracy. And then you see the smattering, like right down to 6 people who got somehow between 0 and 10% of the patients triaged correctly. So that distribution is I find a little bit suspicious. I mean, I find it a bit hard to think that someone could possibly be that wrong, right? That you got only 10% right. It seems like worse than guessing. So it's just something to consider. To me, there's something strange going on based on that histogram. So what were the limitations in this study? Well, first of all, it was used in a simulation setting, and the setting was an online survey where the cases were basically written on the online survey. So whether that is really useful simulation, it's really hard to tell. Everyone has their own opinion on how useful that is. The patient cases they required this interpolation of data as data were not available. A much better study would be able to compare the patient's actual clinical case with all its details versus their outcome. We didn't have that information. This distribution of accuracy on the histogram, I think it suggests there's something wrong. And I don't know if it has to do with how accurate the cases are reflected when they're on the computer screen, or whether there is some problem with the assessment tool. I'm not sure whether people had problems answering the questions based on the multiple choice tool. But to me, it involves further study because it's a very funny distribution of the accuracy. Obviously, no evidence that this works in the field, and this was a very specific target group. We tested this tool only among Italian rescue providers. And being a Canadian, I can tell you that how Avalanche rescue works in Italy is quite a fair bit different than how it works in Canada, and where we have different opinions. So in conclusion, the study shows that the new tool has adequate validity and reliability in expert hands. The tool has poor accuracy when used in non-expert providers. The study here is limited by the simulation format, and we certainly need further study in the field before it can be used. Thank you very much for listening to this presentation.